Hey, this is Dr. C. Nice of you to come and visit today. Got a serious topic today. Tuberculosis. One of the very first times I talked to people about, I give lectures, as you know, for senior issues. And one of the first ones I gave many years ago was on tuberculosis. So I thought I'd revisit it. And not without reason. Yes, we don't have a lot of tuberculosis active in the United States. And that's because of the advancement in the treatment of tuberculosis, diagnosis and treatment. That doesn't mean it's not around. It is around. In fact, around the world, it is still number one bacterial disease, and it is very high around the world in causing deaths of people. Yes, major infectious disease around the world. It's not a virus, believe it or not a virus. It's a bacteria, and they call it mycobacteria. Mycobacteria tuberculosis. This mycobacteria tuberculosis is one member of a large family of mycobacteria. In fact, you may have even heard historically about the Mycobacteria bovis from milk. Now, with pasteurization, you don't hear so much about it. And also, Mycobacteria lepra. Lepers. My gosh. I bet most of you have never even seen someone who has contracted leprosy. Well, the old doc has, and the old doc has taken care of a lot of patients who have tuberculosis, especially when I was doing volunteer work in the third world. And so, this is why I'm here. There are 30 countries that are on the World Health Organization list of high tuberculosis prevalence. 30 nations. Every year they're defined. 30 nations. Guess who's number one? India. Yes, India. And number two, Indonesia. 3, China. All these major countries with major problems with tuberculosis. So of those 30, believe it or not, a lot of the people have immigrated to the United States. For example, most of the Central American countries are on that list. Brazil is on that list. There's a lot of countries with major problems still with tuberculosis. Now, there are 3 phases of tuberculosis. Number 1, the infectious phase. You get the bacteria inhaling the droplets that have the bacteria in it. Pure and simple. Pure and simple. And phase 2, latent tuberculosis. And then you can have, and latent means you have it in you, it still has the potential to become active, but you're not spreading anything yet. It's latent. Doesn't cause any trouble. And number 3, the active disease. Now, 90% of the active disease is in the lung, pulmonary tuberculosis. But there's also extrapulmonary tuberculosis. There we really worry about the kids, the infants, the kids who contract tuberculosis. It can go well beyond the lungs. It can go swell up the belly. In fact, I took care of a couple of kids in Guatemala. Massive belly. Everybody knew what they had. You bring them here, they probably wouldn't have a clue. Massive tuberculosis. You can get Pott's disease, tuberculosis in the spine. In fact, they've defined how far back tuberculosis existed in this world. The tuberculosis was noted in the spines probably from about 5,000 years ago. They already identified tuberculosis in the spine. So it goes back quite a ways, 4,000 or 5,000 years. And over the course of time, of course, things have gradually advanced educationally about tuberculosis, and I'm here to tell you a little bit about it. So, why is it important for us to know? We're living with people from all these countries. We're living with them. We're working with them. We go to events with them. Some of them may be hacking. They may be coughing. And damn it, they can spread it to you. So, that is why I'm talking about it. So, let's talk a little bit more about the tuberculosis itself. As I mentioned, we have stages of tuberculosis, and the countries have identified these stages. Now, what are the countries doing about treating it or diagnosing it? Well, first of all, they may not use what you would consider the modern technology to diagnose it. They diagnose it simply by listening to the cough. They're losing weight. They're hacking up maybe a little pieces of blood in their sputum. They got tuberculosis. They get a chest x-ray and they may see nodules. In fact, tuberculosis, if you go back in time, basically in the Latin word means nodules. So the little nodules in the lung. Well, those nodules can get bigger and then they begin to erode in the middle. And they call that caseation. So it's like a cheesy material within that cavity in the lung. So caseation necrosis. That's how they diagnose it. That's how they diagnose it. Usually they'll see it in the upper lung fields. Again, much worse in the children than it is in the adults. But it can be, and it is fatal. There are a lot of deaths around the world. I'm not talking a few. I'm talking 1 million deaths per year from tuberculosis. And then it got worse once HIV came in. Once AIDS came in, the immune system was destroyed by the AIDS. Remember, it's called immunodeficiency syndrome. Immunodeficiency syndrome, AIDS. And so they're very susceptible to tuberculosis. And in fact, most of the AIDS patients, their cause of death is tuberculosis. Yes, because of that extreme immunodeficiency. So, how is it diagnosed? How is TB diagnosed? We do a skin test called a PPD, purified protein derivative. We did a bunch of them at St. Anne's. In fact, while I was at St. Anne's, we did more PPD testing at St. Anne's than most of the clinics that got paid for all that. Most of the clinics do. We did a huge number. There's still, now we had to buy the damn stuff because the state won't give it to us like they did before, and we're buying it at St. Anne's. Why do we? Okay, so we'll talk about the skin test first, the PPD. What they do with the PPD is a derivative of mycoplasma. I get confused in my older age, mycobacteria tuberculosis. So they use the Mycobacteria bovis, which is similar. It's similar because of the capsule of the cell, tuberculosis cell. it has mycolic acid in it. And so that mycolic acid prevents things from getting in. And also, you can't, the stain that can, you put a stain on it, the stain cannot be knocked out. So they call it acid fast. So they call them acid fast bacilli. Okay, so PPD, nevertheless, we put it into the forearm. Only a tenth of an ml, very small amount, and it has to go in intradermal. So I used a 30 gauge needle, put the thing in, you raise a little bump. They call it a wheal. Raise a little bump up, and then you come back in 2 to 3 days, and we read it. And if you get more than a centimeter of swelling and redness around, it's a positive test, meaning you've been exposed to the mycobacteria. So what do you do then? You do a chest x-ray. If the chest x-ray looks clean, you probably have what they call a latent phase of tuberculosis. So you've had the infection, but you're not infecting anybody else. It's just residing in you, and it's quiet. It's latent. That's it. Now, if you get immunodeficient in the future, that may be a different story. It may turn active. God forbid you should get AIDS. Then you got a 50% chance of getting tuberculosis active. So that is one of the major risk factors. Okay, that's one way we diagnose it. Is that the best way to diagnose it? Well, no. And I'll explain to you what we do and what we did at St. Anne's in the clinic. We would get kids from Brazil or India or whatever, and when they were infants, they got a thing called BCG, Bacillus Camille. And that BCG did prevent serious tuberculosis. So it was very helpful to prevent deaths and serious illness, those PPDs. Those BCG. So they came to this country then, they've had the BCG, but the BCG can make the PPD test positive for a number of years, and it varies with the individuals. Usually after 10 years or so, it dies down and you may not get a positive. But we had a series of all positive tests. Now, if you get a positive test, you have to report it to the state. People know that. They know all these things. They know they had to be reported. So they would cry, oh, we have no symptoms. Their lungs are clear. So, well, let's get a chest x-ray. And I did. And lo and behold, most of them were all clear. So they were in the latent phase. But it was such a problem because of that BCG that we had to have another test that would tell us a little bit. And over the years, they did develop the IGRA tests, and that is interferon gamma release assay, IGRA, I-G-R-A. And so that measured the response to mycobacteria. And where does the response come from? Those lymphocytes that come in and try to fight the disease. And so the lymphocytes would release some substances, and you take the blood test. It's a blood test. It is a blood test. And there's two different kinds of blood tests. One is a spot, and the other one is a routine qualitative or quantitative test for those substances that get released because of the white blood cells' effect on the mycobacteria. Okay, so those blood tests are very accurate and they're independent of BCG. So that's the way we can define whether it's just a latent infection or an active infection. So those are the tests that we do. Now, what about that chest x-ray that we talked about? What does that show? Well, when the bacteria get into your lungs, like I said, predominantly in the upper lung. But the very first thing that you see some heavy, what they call heavy markings, swelling along the bronchial tubes, heavy markings that show up on an x-ray. Then you may see a nodule or two. Of course, later on, that nodule may get bigger without treatment, and you may get the caseation, that cheesy stuff inside that cavity. You always get swelling of the lymph glands, because the lymph glands are trying to fight this infection, and the lymph glands in the central part of the chest swell up, and they show on the x-ray. So if you get nodules in conjunction with swollen lymph glands that you can see, very suspicious of tuberculosis. Now, another way of diagnosing it is to have the patient cough up some sputum. When I was a resident, that's way back when I was a resident back in the 60s, I rotated over at the old Boston City Hospital, where we took care of all of the vagrants and all. We didn't have a great clientele. Had great doctors, though, but didn't have a great clientele. But nevertheless, when somebody came in, we routinely got a sputum, and of course it was the medical student's job, you might say, to look at it under the microscope, stain it, wash out the stain, and then restain with a gram stain. Now, if that stain stayed into the bacilli, they were acid fast. All the others, it dissolved out. But because of that cell wall of the tuberculosis, it retained that stain, and you could see the little red, we use red stain, obviously, so we could see the little red bacteria. We call them red snappers back then. So I would go over to the resident then and say, I got some snappers on my slide here. Well, take a look. Okay, yep, got tuberculosis active. So that's what we did back then. So more definitively, you can send that sputum for culture, and eventually you can culture out the mycobacterium, eventually. But that takes time. The slide that we did was immediate. So we could diagnose it so that by the morning we could present it at the rounds as a positive acid-fast test. The test that you send to the lab to confirm that and grow the stuff takes about 2 to 3 weeks. So that delays treatment considerably. Okay, so let's go on from there. What about our treatment of this bacteria, this mycobacteria? Well, you don't remember. A lot of you don't. But we had sanitaria here in the Worcester County. Tuberculosis sanitaria. The first one was in Rutland, very close, big Rutland TB hospital. Then they opened one up in Worcester after that. And there was another one out in the Westboro area later. But the biggest one was the Rutland sanitarium. And did you know, incidentally, that we actually had a leper farm? Yes, we had a leper farm over on the coast, on the Cape. Not for long, maybe about 20 years or so, but they've had people with leprosy because we thought, we didn't have active treatment then, we thought that good nutrition, fresh air, and all, and getting them away from society was a good thing. And so that's why we developed the sanitarium. So in retrospect, it wasn't a bad idea, and it probably saved a lot of lives. But that was then, and this is now. Surgery did play a role in the treatment of tuberculosis as well, but what we did back then was to excise a piece of the lung that contained that caseating necrosis in the nodule. Take that piece out. Another way of doing it was to contract the lung. And so taking that piece out, contracting the lung down, so when somebody came in, say a year later, got a chest x-ray, small lung on this side, big lung, normal on the other, they had previous TB surgery. So these were all things that were active back then. This is what we did. So, okay. So those are historical, I know, but hey, listen, that's just the way it is. Now, there are complications of tuberculosis. We talked about extrapulmonary TB. We talked about the kid in Guatemala, the kids that I took care of with big tuberculous peritonitis, big belly full of fluid. There are people with that Pott's disease still in other countries with tuberculosis of the spine. Not an easy thing to treat. And you can also get it in the brain. Meningitis. Not a good thing to get. Definitely not a good thing to get. So it can infect other organs as well. So remember, the mycobacteria include also things like leprosy, like I said, and so it has the capacity to invade into skin as well. So let's talk a little bit more about what kind of modalities are available here, now, in this day and age for tuberculosis. Well, let's say you have active tuberculosis. And who do you see? Where do you go? Well, there is a clinic at the old Hahnemann Hospital. It's called the Getchell Clinic, Getchell. And it is a tuberculosis clinic. And so they have the capacity to diagnose accurately and treat tuberculosis. And so they treat many of them, probably most of them, as an outpatient. Because the treatment time, the treatment of tuberculosis takes 6 to 9 months in general. In general. And what do we use? We use a combination of drugs. Isoniazid, probably doesn't mean anything to you. Rifampin, again, probably doesn't mean too much to you. And now a couple of other more modern drugs as well, but those two are still mainstays. Caution, one caution. We're getting an increased number of people who are resistant now to the general chemical treatment of tuberculosis. So they are resistant people. And the number now are increasing around the world. Up to maybe about 15 or so % of people now who have tuberculosis are resistant to the drugs that treat it. Oh, big deal. Yes, it is a big deal because it's so common around the world. And so it's getting worse. We're getting more resistant cases, and that is a big issue. Okay, so what other things can I talk about? Well, I can talk about the history of it, but that would just bore you to death, I'm sure. Let's talk for a moment about, things that are more common to you. Again, for those of you who remember the sanatoria, I talked about the Rutland one, the one on the West Boylston line in Worcester. That's right, actually near the jail facility out there at that line. So what is that, Route 70 or whatever? Yeah, it was very near there. And they also had one in Mattapan in Boston. And they all closed in the 1980s and maybe late 1980s. And I have an interesting story about the closure of the Rutland Hospital. Back then, I was going on missionary trips and I had a lot of material. Being a surgeon, of course, I wanted to help doing surgery down there. So I needed instruments. Well, when the hospital closed, that Rutland Hospital closed, they just said, let's clear it out. We're gonna knock it down. Take what you can out of it. And so one Saturday, I drove up to Rutland, parked right near about a half a dozen state trooper cars. Now, what did they need the stuff for? To sell it, of course. So I went through there. I packed my car from that Rutland Hospital. I had enough instruments then so I could carry on with my foreign treatment, my foreign surgeries, with good instruments. They were good instruments. So that was my story about the Rutland Hospital. That's how I came about looking into the history of it, actually. So, oh well. So that is, in a nutshell, tuberculosis. And I should mention that even today, there was an article in the paper about tuberculosis. The United States now has abandoned USAID, canceled it. They're not going to contribute to it anymore, and we were the major contributor. This was a fund that took care of health care in many different countries, especially tuberculosis. So, what's going to happen with the defunct now USAID? I don't know, but it isn't good. This is Dr. C. Have a good day.